Topic of the lecture today is myocardial hypertrophy and heart failure. We're going to talk about what myocardium is and how it leads to heart failure. First of all, let's talk about myocardium. You all have heard the name of myocardium in one system or another, but specifically in the cardiovascular system. So, what is myocardium? Myocardium is actually a collection of individual myocytes which come together and form this myocardium. And what is actually a myocyte? Myocyte is actually a singular cell with mostly a single nucleus, sarcoplasmic reticulum, uh, further on endoplasmic reticulum, then further on mitochondria, and all of those structures are present. Now, two myocytes, when they're together, they are separated basically by intercalated discs. These two myocytes, which are going to come together, actually they make up the heart. So the individual cells, they make up the heart in contractility manner. So these are two cells, they're separated by intercalated discs. Now, what do those discs perform? What are they there for? First of all, they're there for the cell to cell adhesion so that they don't go far away, they don't get pulled too close so that they won't be able to even contract. So these are cell to cell adhesions which are present in this manner in integrated discs. And further on, what does integrated disc hold more for them? It holds the current, the electric current. This integrated disc helps in that manner. It distributes that flow of current, that flow of energy inside the myocyte. So they are separated by intercalated discs, which separate them and keep them together, not too far away, and they provide them with electricity. But they provide them with a cardiac electric cycle or rhythm, which are supposed to be regulated, and it plays a major role in regulating that. So let's talk about myocardium. So before we go on to myocardium, here's the heart. First of all, let me tell you, heart is enclosed by three layers. The outermost is epicardium, then comes myocardium, then comes endocardium. Now these are three layers. You have to remember them in this manner. Epicardium on the outer side, then myocardium, then endocardium. And then heart is enclosed by basically pericardium. And pericardium has two layers. One is outer layer, one is visceral layer. And between them is pericardial cavity. And that's very important. You'll get to know the pathologies which involve that cavity, which involve that space and affect the heart in some manners. So these are the membranes that enclose the heart. Now, when we get into the heart, now this is the heart. Now, when we get into the heart, we talked about myocytes. Now we talked about that myocyte is a singular cell with a nucleus. It is separated by intercalated discs. It has endoplasmic reticulum. It has nucleus, mostly singular nucleus, and all of those structures. Now, when the bunch of myocytes come together, they make myofilaments. And myofilaments are stacked on each other. They're stacked on each other and they form sarcomere. Now, sarcomere, you'll read in your books that sarcomere is a contractile unit of heart. Sarcomere is made up of myofilaments. That is made up of, we talked about, myocytes. Now, we talked about these layers, myocardium, epicardium, endocardium. Now, this myocardium is present, which is surrounding it. Then endocardium comes in. Then we talked about myocytes. Now, what happens that any of it is affected? That will lead to any kind of pathology that we'll get to very soon. So before we head on to any more, we have to understand the basic structure of myocardium. What is the basic structure of myocardium? Now, this is a basic structure of myocardium. This is T-tubule. Further on, we have MI. Next on, we have sarcoplasmic reticulum. Next on, we have a Z line. Then we have SL. Next on, we have this M line. Then there are these I bands. And further on, we have these A bands. So now let me tell you what these Z lines, these M lines, these I bands, these A bands are. We talked about sarcomere, right? In this structure, we have heavy chains, we have light chains. Now, heavy chains and light chains both are present, both are there, but what they're made up of is different. Now, this I band annotates the light chains. It contains troponin, basically. On the other hand, A band contains all the other necessary elements for this contraction and non-contraction or relaxation coupling. It contains all the enzymes, it contains all the structure which is required. So this A band basically annotates the heavy chains, and the I band basically annotates the light chains. And you see they are interdigitating, they are connected. And how a sarcomere contracts, how a myocyte contracts, how the heart contracts depend upon this relation, depend upon this interdigitation. Now, between them, there is Z line. Z line annotates from one place to another. Between them are heavy and light chains. So Z line actually annotates a border between these. So Z line annotates that these are the structures: T tubules, MI, sarcoplasmic reticulum. We know all about these cell organelles which are present right here, which get affected by all of these contraction relaxation couplings and this regulatory mechanisms. Now further on, between them there is M line. Now tell me if there's shortening of it, if there's shortening of the structure, which of these lines will get disappeared? This M line. And without moving forward, here there's an H zone. We'll talk about it further when we get to the pathologies, and H zone will come up. But between this A band, there's this H zone, which is very minute, which is just like M line. It's very minute in size. So it's not even recognizable in normal structures, but it's there. So two lines or two zones which get disappeared when there is shortening of this whole structure are H zone and M line. If there is shortening of them, or if they're not there, it means it's shortened, it's shrunken, because it's so minute in size. So what we gather from this slide is that heavy chains and light chains are interdigitating, and the dependence that how hard or how strongly it's contracting or relaxation is going on depends upon this structure, depends upon this relation between them. So this is how it contracts. Now let's talk about within the myocardium what happens. So this is a structure. What happens is that calcium came in and contraction started. Now let's talk about how did this happen? How did this happen? So before getting to know that, what happens is that whenever there's any kind of electrical changes in the heart wants to contract. What does it do? It opens the calcium channels. When calcium channels are opened, what do? They go to the cells, they affect the heart in that way. So let's talk about how does it affect the heart. So the calcium came in. Their L-type calcium channels are present right here. Now these L-type calcium channels will give entry to the calcium. The moment it enters the cell, it enters the structure, RYR receptors pick it up, they put it inside of it, and when in sarcoplasmic, it's sarcoplasmic reticulum. This organelle is sarcoplasmic reticulum. It's stated right here. SR stands for sarcoplasmic reticulum. When calcium comes in, what happens is that sarcoplasmic reticulum takes upon it. When it takes upon it, it produces more calcium in response to this calcium. Sarcoplasmic reticulum already has calcium inside of it stored. So, in response to the calcium coming from outside, it gives off that calcium and more to the cell. What's calcium going to do? Calcium is going to go to the mitochondria, going to get inside. Now, when it gets inside, this whole, you can see these microfilaments, heavy chains, light chains, they're going to contract because calcium is present inside the cell. Now, that whole thing has happened. Now, contraction has happened. Now, the phase of relaxation is to come. Relaxation is to come. So, how does that relaxation comes when calcium is present inside the cell? The cell won't relax until the calcium is out of the cell, or even up to that level which is normal inside the cell for it to relax. So for that purpose, we have all of these gates present which won't let the calcium stay in, which won't let the threshold of calcium which is required for contraction, won't let it stay inside the cell. So let's talk about it. You can see this calcium, if it's the moment it gets inside the cell, if it's more in current quantity, we're going to use the ATP and throw it out of the cell. Further on, we have these sodium calcium channels, and with 3 sodiums will come out and calcium will go out. Next on, we have these sodium potassium pump, sodium potassium ATPase pumps. What do? They put the sodium out, because to get the calcium out, we are putting so much sodium inside the cell. So that needs to be checked, so the electrical imbalance doesn't happen. Because if electrolytes are going to be imbalanced, it's going to lead to that. So if more and more sodium is coming into the cell, because we have to push the calcium out, there must be some channels which put the sodium out. Otherwise, there will be hypernatremia. So 3 sodium will go out and 2 potassium will go out through this ATPase pump. Further on, this sodium hydrogen pump, so that sodium doesn't get depleted in this whole manner. And then we have to tell you that this response, yes, it happened. Yes, it came inside the cell, but there's another way of calcium to enter the cell, and that's to sodium calcium pump, in which calcium comes in and 3 sodium go out into the T-tubule. So what we learned is that calcium, when the contraction was required, calcium came in to the T-tubule. From the T-tubule, it was uptaken by R. The moment it entered the sarcoplasmic reticulum gave more and more calcium. When more and more calcium was present, contraction happened. It goes to the mitochondria, it does all of this. When contraction has happened, for relaxation to happen, calcium needs to be expelled out of the cell. When it's going to be expelled out of the cell, it needs all of these gates so that it can be pushed out of the cell. And when there's contraction required, again, this whole cycle will come into the moment again. I hope you got the point of it. Next on, we have myocardial hypertrophy and heart failure. So this is a normal heart. So how can you say it's normal? Because the size of the right ventricle is smaller than the size of the left ventricle. Mostly it's 0.5 centimeter in size. But this is 0.8 to 1.5 centimeter. Why the walls of left ventricle are thicker than the walls of the right ventricle? Because it has to push a larger amount of blood into the system against a higher degree of pressure. You must have heard these readings that I have a blood pressure of 120 by 80, 140 by 80. What do that mean? 140 means systolic pressure. It means the heart has to push at 140 to overcome that. It's the pressure of this blood coming out of it. So the heart has to work more. It has to pump at a very higher pressure so that the blood gets to every cell inside the body. It gets to your toes, it gets to your head. All of that depends upon the left-sided contraction of the heart. So with time, it grows thicker in size. But it's not pathological. It's totally physiological. There's no harm in that. So it keeps pumping the blood. So the left ventricle walls are thicker than the right ventricle. So this is normal heart. You can see it's normal. These walls are thin, these walls are thick. What happens afterward? You got stress. What kind of stress? What kind of stress will lead to myocardial hypertrophy and heart failure? For example, you have more and more atrial pressure, right sided atrial pressure. What does that mean? It means you have more and more venous pressure. Right sided atrial pressure means the venous pressure. We cannot measure the pressure of the venous or of the veins. We cannot measure the pressure of venous system unless it's inside of this chamber. So the pressure present on the right atrium, present inside the right atrium, is actually annotates the pressure of the venous system, because it's actually returning from the veins. It's coming from that pressure. So this venous return, which is present inside the right atrium, annotates the pressure. So what happens that if there's any pathology inside the system and the venous return has increased, so what will happen? Right atrial pressure will increase. So when these pathological things will start happening, the heart will go into stress. Now right atrium has more pressure, it's contracting more and more blood. Right ventricle is getting more and more blood, so right ventricle pressure will rise to push the blood out of it into the pulmonary veins. Into the pulmonary arteries. Now what happens? This will give stress to the heart. For example, a patient is in hypervolemia. What will happen in hypervolemia? Venous return has increased dramatically. Now that right atrial pressure, which was supposed to be very low, now it's very high because it's getting more and more blood. It has to pump more and more blood in very minute time. Now this is stress. So what will myocardium do? What will myocardial hypertrophy will be here? What will myocardium do? These cells of myocardium will elongate. They'll stretch. When they'll stretch, they'll give those receptors, those molecules which will increase the proliferation of myocytes. When more and more myocytes are being produced, it's under the stress. But if the stress is limited, it leads to reversible hypertrophy. That hypertrophy can be reversed with time. And if the stress is here, it will lead to compensated hypertrophy, which is reversible in nature. Now this is compensated. You can see if there's more right atrial pressure, more right ventricular pressure, what will happen here? More left atrial pressure, more left ventricular pressure. So this is actually a compensation. All of these walls are thickened in size from their normal values, from the normal size, because the heart is compensating. The heart is pumping more and more blood in less and less time, but it's compensating. Still up till this point, it's compensating. It's doing this. It's rhythmic. It's doing everything it needs to keep it in normal shape. But what will happen if this stress is for a long time? And the example is chronic hypertrophy, which will be because of many reasons. Main of them, very basic of them, is hypertension. A patient who has been suffering from chronic hypertension for a long time. So the compensated hypertrophy did happen. It did its work, it did its charm, it stopped it from happening, it stopped it from going to permanent hypertrophy. But up till when? We didn't control the blood pressure. So one time or another, this will lead to permanent kind of hypertrophy, and that will lead to decompensated heart failure. It was compensated up till this point. Now it's decompensated heart failure, and it happened due to persistent stress. We didn't treat the cause. And now you can see the walls of it. Now the walls are not thickened. They're just lax. They're just, if the rubber is going to be stretched, up till some point it will be stretched. But if you pull it apart after that threshold, it will just go that way. It won't even come back. That's what happened to heart. Now the walls are thin. These spaces are large. Now this heart won't be able to contract that good. I mean, if heart was like this, and pumping the blood outside of your right and left ventricle. Now the heart is like this. It's not working enough. It's not working in its vital capacity, its proper capacity, because the walls are not working like a pump. It was working like a pump like this, but now the walls are thin. They won't even come together. It will be just this, and some part of the blood, not even 60%, which is normal ejection fraction, not even 60% of the blood present inside the left ventricle will be ejected because it has reached this decompensated heart failure stage. Now what will happen? There will be a lot and diastolic volume left inside of it. At the end of diastole, the volume left inside this chamber is called end diastolic volume. Now more and more end diastolic volume has been retained. So it will lead to decompensated heart failure, and the prognosis of the patient gets worse and worse after this. Now this was stress and it led to compensated kind of hypertrophy. But what if the stress is so severe that it led to decompensated heart failure directly? It didn't go into this stage. So that means that the level of the stress was so high that it even didn't give the heart a chance to adapt to it. In hypertrophy, if it's due to hypertension, heart has time to collaborate, to increase in size, to compensate. But what if the stress was so severe that it didn't even get the time to get here, to do this compensation stuff? Now, that kind of stress will lead directly to decompensated heart failure. So this is a myocardial hypertrophy and heart failure will be looking like. Now, you'll be thinking that we have heard that athletes have hypertrophy of myocardium. Now, this concept is not yet clear, but yes, athletes do have hypertrophy. But their hypertrophy is called physiological hypertrophy. And the patients we're going to deal with, they're going to have pathological hypertrophy. What's the difference? That physiological hypertrophy came into existence because that person who is that athlete who has a physiological kind of hypertrophy went into a lot of struggle. That athlete ran, heart needed to pump more and more blood, and at some point heart decided, okay, we need more and more myocardial cells so that we can contract up to this limit. There was no pathology involved. So that kind of hypertrophy led to a physiological hypertrophy. But when we're talking about this kind of stress or persistent stress or severe stress, one way or another way, it will lead to decompensated heart failure, and we won't be able to do anything about it. Next on, we have myocardial hypertrophy and heart failure in terms of Frank-Starling law. So this is a curve. This curve is called Frank-Starling curve. So what is a Frank-Starling law? You can depict it right from this graph. That what is Frank-Starling law? That when there's more left atrial pressure, there will be more ventricular work, there will be more stroke volume. More left atrial pressure, more stroke volume. More left atrial pressure, more stroke volume. More blood coming into the left atrium and then left ventricle, more stroke volume. And diastolic volume, stroke volume. And diastolic pressure, stroke volume. All of these affect the stroke volume, affect the ventricular work. What is ventricular work? To put the blood out of it. And what is it called? Stroke volume. Mostly, what's the stroke volume? 60% of the blood present inside the left ventricle goes out of it. That's what is called stroke volume. So in Frank-Starling curve, when we increase the left atrial pressure, ventricular work increases. It goes up, up, up. The more left atrial pressure, the more ventricular volume. The more atrial pressure, the more ventricular volume, up till this point. Now, at this point, there are two factors we have to consider. Which two factors might that be? That if it's happening because of a physiological reason or because of a pathological reason. What can be the physiological reason? What can be the pathological reason? Physiological reason might be the presence of norepinephrine. If it's because of norepinephrine inside the system, if it's because of norepinephrine inside this blood, inside this myocardium, it's going to be this curve, this X curve. It will keep on increasing. It will keep on going up. But what if this is because of a pathological reason? What if it's because of chronic kind of heart failure? What if it's because of persistent hypertension? What if it's because of myocardial infarction? Any of those can happen. So what will happen to the curve? It will go downwards. Up till this point, it's the same. This result is the same. But after this, it's going to go up, and this curve is going to go down, because now it has reached its maximum threshold. And if it's because of a pathological reason, even these cells are not even strong enough to go after this point. So this curve will go down. It won't follow the Starling curve. It won't follow this direct relationship between them. But that direct relationship lasted up till a specific point. Afterwards, it didn't support the cause. So what conditions are there when left atrial pressure will be so high that it leads to the downward shift of the curve? Any condition which increase the end diastolic volume. And when will the end diastolic volume will increase? When there's more and more blood coming inside of your left atrium. And when will that happen? When there's more and more blood coming out of your right ventricle. But when will that happen? When there's more and more blood present inside of your right atrium. And when is that going to happen? When there's more and more venous return. When the venous pressure is too damn high. And when is that going to happen? Any kind of pathology which leads to increase in pressure and venous return will lead to this state of the heart, will lead to this Frank-Starling curve, in which it will follow this whole phenomena that left atrial pressure and diastolic volume and diastolic pressure, all of these are in direct proportion to stroke volume up till this point. Afterward, if it's physiological and it's because of norepinephrine, the curve will go up. But if it's because of a pathological reason, it will go down. Next on, we have pathophysiology of it. So this is a normal adult heart. It has its right ventricle, it has its left ventricle. Now the diameter of the left ventricle is more and the diameter of the right ventricle is less than the diameter of the left ventricle. But note the thickness, it's more thickened, it's less thickened. So this is normal heart. We know the physiology of it. This is how the cardiomyocyte will look like. This is the width of it. This is sarcomere, the contractile unit of it, heavy chains, light chains, all of that. And this is the length. Now, look at it. Keep this picture in your mind for your future references, that what a normal heart will look like. This is how it looks like, and this is what its cardiomyocyte will look like. So what happens afterwards, that either it's going to be physiological stimuli or it's going to be pathological stimuli. We talked about it. What is going to be the physiological stimuli? Norepinephrine, exercise, athletes. What is going to be pathological stimuli? All of those diseases we talked about. All of those conditions which will increase the preload, then will increase the afterload, and on and on and on. All of those diseases which increase the venous return. So, physiological stimuli will lead to physiological hypertrophy, and pathological stimuli will lead to pathological hypertrophy. Now, this is a physiological hypertrophy will look like. One thing you have to notice that the hypertrophy will be eccentric. Eccentric meaning proportionate. Now, look at it. This was a normal heart. If it's even hypertrophied, it's hypertrophied to very same extent. It looks like this picture has been zoomed in. That's it. Not zoomed out, not that this part has been increased or this has not. It just looks like that it has been zoomed in. So that's why it's eccentric hypertrophy, and it happens in those people who have this physiological hypertrophy due to a physiological stimuli. What will happen to a patient who had this pathological stimuli? Concentric hypertrophy. Concentric means partial hypertrophy in one places and more hypertrophy in the other places. Now, take a look at it. Now, this structure has been increased in size. This structure has hypertrophy. This right ventricle has hypertrophied, but the left ventricle, it is actually shrunken. It is not hypertrophied. And what will a cardiomyocyte will look like? This is how it will look like. Now, this was the normal cardiomyocyte, and now this is the pathological cardiomyocyte. And this is the normal, and this is the physiological. You can see width didn't increase, width stayed the same. A little increase, but now look at the width. It's actually double. What happened to the length? Yes, it lengthened, so did this, but it's more lengthened. What happened to this? You can see it stayed in the same place, it moved up. So this is a pathological stimuli which led to pathological kind of hypertrophy, which is called concentric hypertrophy. Now, due to this, mitochondrial dysfunction and cell death will happen. And afterwards, what will be the effect? This kind of hypertrophy. This is called eccentric hypertrophy. This was concentric hypertrophy. Now this is eccentric hypertrophy. Eccentric hypertrophy means that mitochondrial dysfunction has happened, mechanical unloading has happened. So this left ventricle has increased in size too much, but its thickness has gone down. This was the thickness, it has gone so down that now the heart doesn't even work as a pump. We talked about this was the heart, it was working as a pump. This was pushing the blood out. Whenever this happened, the blood pushed out, the blood rushed out. But it's not rushing out anytime soon because now these walls are very thin and all they can do is this. A very minute amount of blood will come out. Not all of that blood will come out. Not even 60% will come out. So pathological stimuli will lead to concentric or eccentric hypertrophy. In concentric hypertrophy, okay, we have this hypertrophy or even this will stay in the same size, but left ventricle will shrink in size. And then after the mechanical unloading and mitochondrial dysfunction, left ventricle will go nuts. It will increase in size. Its width will go down. It will lengthen so damn much that it won't be able to come back. The sarcomeres, this cardiomyocyte won't be able to even contract properly. When they won't be able to contract properly, if individual cell is not working properly, what will happen to the organ? The organ won't be able to work as a pump. So these are the pathophysiologies of physiological hypertrophies and pathological hypertrophies because of different kind of stimuli. Now this concentric hypertrophy and eccentric hypertrophy led to heart failure. As you can see, heart failure. And this all happened because the heart is not working as a pump right now. It's just merely contracting up to a point till it can. Afterwards, cannot even contract because those structures are not working as they were supposed to work. This pathological stimuli may lead to directly heart failure. They won't even lead to this kind of hypertrophies, and that happens in any kind of sudden ischemia, any kind of sudden diseases, any kind of sudden arrests that will lead to heart failure. Now we have molecular pathogenesis. What happens at a molecular level? This is a normal myocardial cell. Myo means muscle, cardial means heart, so cardiac heart muscles. So normal myocardial cell, it has its nucleus. We talked about it has one nucleus. It has all of these structures. It has its calcium going in, calcium coming out, these calcium channels which will help it to contract. It has its extracellular matrix. It has its beta adrenergic receptors to act on so that if we have to run, if we have any kind of stress, what will happen? Norepinephrine will come in. It will act on these receptors and it will increase the cardiac load. It will increase the cardiac work that we require to get out of that kind of situation. Next on, we have this norepinephrine binding and going back. We talked about it. This is required when we have this kind of stress, or we have this emergency, or we're doing the exercise, or we're running as an athlete. We have this sarcoplasmic reticulum in which calcium is going in, calcium is coming out. Next on, we have adult isoforms of myofibril proteins. These myofibril proteins are in adult form. Now, you might be wondering what other isoforms are there. There's this neonatal isoform, and then there's adult isoform. Now, in neonatal isoform, the moment the birth happens, or the child comes out of the mother, this isoform changes to adult isoforms afterwards. But if it's in pathological forms, this adult isoform won't be able to cope with this kind of pathology. So it shifts back to neonatal isoforms. Now we have to differentiate between these two. We have to compare these two. Now look at it. This is a hypertrophic cardiomyocyte. This is the pathological molecular level. Now look at it. We had these beta adrenergic receptors which were more in quantity. Now it's less in quantity. Why? Because it's already hypertrophied. It's already working at its maximum capacity. It doesn't need all of these. So still the structures remain there. Beta adrenergic receptors are there. These are norepinephrine coming in and going out. So beta adrenergic receptors went down eventually. These receptors went down. This norepinephrine stimuli went down because of this hypertrophic cardiomyocyte, because of this hypertrophy which happened due to a pathological reason. Next on, we have fetal isoforms of myofibril proteins. We talked about it. There are two kind of isoforms of myofibril proteins, fetal and adult. So it shifted from adult isoforms into a state in which it had both of isoforms. Then it shifted permanently into fetal isoforms so that it can cope with the pathology that's going on inside this cardiomyocyte. What is ANF? Antinucleotide factor. Okay, ANF. So these are the calcium channels. Now it had various minute amount of calcium channels. Now it has more and more calcium channels because it's contracting. It's contracting very rapidly. It's hypertrophy. It needs more and more calcium for doing that work. So the level of calcium channels has increased. Calcium channel uptake by sarcoplasmic reticulum has decreased because it's coming out of it. Now calcium channels, when it's not going to be going through this sarcoplasmic reticulum and the uptake by sarcoplasmic reticulum has decreased, now the cell needs calcium, so it's going to take the calcium from outside the cell. So the level of calcium will still be more than it was inside the normal cell. So the level of calcium increased, but the beta adrenergic receptors decreased. That adult isoform changed into fetal isoforms, and next on we have increased extracellular matrix, because when all of this is happening, all of this stress is going on, it secretes more and more extracellular matrix. Now these are TGF beta. So what are the basic reasons behind it? All of this happened because of these things. When angiotensin 2 happened, when endothelin, insulin growth factor 1, cardiotrophic cytokines were released, or cardiac growth factors were released, then it led to this kind of hypertrophy. So if angiotensin 2 is there, it means that it has angiotensin 1. If not even angiotensin 1, angiotensinogen is there. So if we give the patient angiotensin blockers, ACE inhibitors, they're called ACE inhibitors. If ACE inhibitors are given, what will they do? They'll shift this remodeling back into normal cell. That's why in new patients who are suffering from this kind of disease, ACE inhibitors are preferred because they're going to remodel the heart back to its normal structure. Endothelin, insulin-like growth factor 1, cardiotrophic cytokines, all of these factors are going to lead to hypertrophic cardiomyocyte because all of them leads to more and more calcium uptake, more and more extracellular debris going out, more and more extracellular matrix going out. TGF beta will come in the play. Sarcoplasmic reticulum function will go down, more and more calcium will be coming out of the cell. So these factors affected the heart and led to the heart or the structure in this shape. So if we want to remodel the heart back to its normal structure, we can give the blockers for it. And they will stop it from happening or at least halt it in the process. And further on, we can remodel the heart by giving the blockers. Now let's talk about heart failure. What the term heart failure means? What is heart? Heart is a pump. What's the function of heart? The function of heart is to pump the blood to all the body cells, to all the body tissues, and provide the cells and the tissues and the organs with the necessary kind of blood and nutrients. So in heart failure means that heart is unable to do its function. That's why it's failed. That's what heart failure means. What are going to be the causes of heart failure? First of all, we have ischemic heart disease. What is ischemic heart disease? It means that heart didn't get enough blood supply of its own. Now, heart is supplied by which arteries? Coronary arteries. You have to remember it. Coronary arteries supply the heart. The branches of coronary arteries are present throughout the heart, are present on the outside, inside of the heart, so that it can provide the heart, the muscles which are contracting with normal and sustained blood supply and oxygen levels and nutrients. So if anything happened in coronary arteries, if there's any blockage in coronary arteries, if there is any thrombus in coronary arteries, it will lead to ischemic heart disease. Now that coronary artery is blocked. Now it's supplying the blood up to some level, but it's not supplying the blood and oxygen up to the level it is required. So what will the heart do? Heart won't be able to function. Heart will try to compensate for it, but up till some point it will compensate. Afterwards, if the blockage is too much, those cells which didn't get the blood supply, which didn't get the proper oxygen, will die. When they will die, this will lead to the failure of that part of the heart. That part or those cells won't be able to function afterwards. This is called ischemic heart disease. It means ischemia is happening. Ischemia means not enough oxygen is present for the cells to function. So when these cells are dead, they're dead. So ischemic heart disease is the major reason of heart failure. If ischemia was so major that it blocked the whole artery, it blocked the whole branch of an artery, and that whole area didn't get the blood supply, that whole area will die. And even a patient can die because of ischemic heart disease right away if the blockage is too major. Next on we have ventricular hypertrophy. Ventricular hypertrophy happens if there's more preload, if there's more and more right atrial pressure, when there's more and more volume in the right ventricle, when there's more and more return from the pulmonary vessels into the left atrium and then into the left ventricle, and the heart has more and more function to do. That left ventricle will try to compensate. It will compensate, but it will be pushing a lot of blood. So when the left ventricle pushes a lot of blood, it needs a lot of force to push at least 60% out of it. So what will happen? Hypertrophy will happen. Hypertrophy, that kind of hypertrophy is due to stress, not due to physiological reason, due to stress. We talked about what stress does to it. So when this hypertrophy is because of stress, those cells are enlarging. They're losing their capability to contract properly. And up till some point, it will be compensated. It will be compensatory. It's reversible. But when it exceeds that threshold point, afterward, it's not coming back. So that kind of ventricular hypertrophy will lead to heart failure. How? If ventricular is hypertrophied, it won't be able to work as a pump. It won't be able to pump the blood like this. Now it will pump the blood like this. Very low blood pressure. The heart will be able to pump some part of it, some part of the blood, not even 60%. So the blood won't be able to compensate all the body needs with oxygen, with blood, with nutrients. And if it's not compensating, if it's not providing the body with proper nourishment, oxygen and blood, heart is failing. That's what heart failure is. That's what we call the heart failure. So let's talk about the pathology. What will the gross structure will look like? We're talking about that it's hypertrophied, its hypertrophy is happening, but the walls are going thin. What's actually happening? Let's look at it at the gross section of the left ventricle when it's leading to hypertrophy and then leading to heart failure. So this is a normal heart. Can you guess which of them are left ventricle and which of them are right ventricle? Yeah, this is the left ventricle because of the walls. Look at the walls, thickened walls. So let's take a cross section out of it. Now this was right part, this was left part. The walls are thick. It would push all of the blood, at least 60% of the blood out of it with its contraction. It's in this shape, it's contracting like this. It's efficient. It's doing its work. But now the hypertrophy is happening. Now the cells are reacting to hypertrophy. Now it's widening. Now look at it. Now this has hypertrophied, but the walls are the same for the right ventricle because they were thin before even that. But what happened to this level? Now it has hypertrophied and the walls are not that thick. The size has majorly increased. Yes, the size of the left ventricle has increased. The size of the left ventricle was this. Now it has increased to this level. Yes, the size has definitely increased, but the walls are going thin. But still, it's compensatory. At this point, we can compensate it by giving the drugs. We can give it ACE inhibitors. We can stop the remodeling of the heart. We can give all of those blockers which were being used inside the heart for the hypertrophy. We can give all of those blockers, like ACE2 was being used, we gave ACE blockers, ACE inhibitors. So at this point, we can intervene and stop the heart from going into left ventricular hypertrophy. But if it was so major, the stress was so major, either it was so major or it has persisted for a very long time, the walls have gone so thin that you cannot even appreciate the difference between left and right ventricle. Look at them. Both of them have hypertrophied, but the walls of the right ventricle were the same. They're not affected that much, but look at the walls of the left ventricle. Now, the walls are so thin and the space is so major that even if it contracts properly, it won't be able to push that amount of blood out of it. But as it has stretched so long, now this was the level of sarcomere. Now it has stretched, it's hypertrophying. Up till this point, it's working. But what have happened at this point? It's not working properly. It will lead to at least a maximum amount of this kind of pump activity. So it has stretched that long that even the major units which are responsible, sarcomere, which are responsible for contraction are not working properly, are not working at their best capacity. So this will lead to increase in the size of left ventricle, but decrease in the size of the walls, decrease in the pumpal activity of the walls. Now this left ventricle is unable to contract properly and provide the action of the pump the body requires it to have, and the blood won't reach all the cells, and blood won't be able to nourish all the cells because even the blood is not coming out enough. So this will lead to hypertrophy, and that hypertrophy will eventually lead to heart failure. What will it look like on a slide? Look at it. More and more units are present inside of this muscle. But look at them. These are hypertrophied, but the amount of them is decreased. That's how you'll see it on the left ventricular hypertrophy slide. Next down, we have pathology of severe myocytolysis. Now look at this. You can see only the empty cytoplasm, the enlarged, hollow cytoplasm. Why would they be able to work properly? They don't even have proper blood supply. They don't even have proper extracellular matrix surrounding them. So they're just hollow. So they won't be able to contract properly. They won't be able to do the proper functioning of a pumpal action. Next on we have left and right heart failure. Let's differentiate between these two, that what a right heart failure is, what a left heart failure is. Before we go on, let me tell you what right heart failure is. Right heart failure means failure of right atrium to get that blood which is coming out of the venous system, failure of the right ventricle to get that blood from the right atrium. So if the right ventricle is failed, what will happen? Right atrium is going to fail. It's going to pool the blood in right atrium, but the right ventricle is not taking that much blood. It will hypertrophy. It will fail eventually. If the right atrium is failed, what will happen to the venous system? Now all the blood was coming from the venous system into the right atrium. Now if the right atrium is failed, right ventricle is failed, what will happen to that blood which is coming out of the venous system? Now right atrium is taking the blood, but it's not taking the proper amount of blood which is required. The preload is decreasing somehow. So the blood is in line to get emptied. The veins are in line to get emptied into the right atrium. But because right atrium it won't take it. So what will happen? The pooling of the blood will start in the veins. When the pooling of the blood will start in the veins, what are going to be the consequences of it? First of all, congestion of peripheral tissues will happen because the veins are pooling the blood. Right atrium is failing, right ventricle is failing. So the congestion of peripheral tissues will happen. Next on, it has three consequences. It will have dependent edema and ascites. Dependent edema in those places where we sit, like dependent edema means I'm standing. So all the pressure is on the legs, so edema will develop there. Why is edema developing? Because this pooling of blood, the fluid and those matrices will shift. The fluid will shift out of the cell. The fluid will shift out of those capillaries, out of those venules. So edema will start developing. And if it's in the abdomen, ascites will happen. So next on we have GI tract congestion. More and more blood is pooling, GI will be congested. And what's the further point? What's the further point will it be led on to if GI tract is congested? It will lead to anorexia. It will lead to GI stress. It will lead to weight loss because food is not being taken up properly. Food is not being digested properly because GI tract is congested. Next on we have liver congestion. Because of this pooling of blood, we have liver congestion and signs related to liver failure or liver impaired functions. Next on we have left heart failure. What does the left heart failure mean? It means the left side of the heart is failing. Left side of the heart means left atrium is failing. Left atrium is getting the blood from where? Pulmonary vein. So the pulmonary vein, after getting oxygenated blood, is coming back to the left atrium. So if the left atrium is failing, it's not taking that much blood, the blood will start pooling in that direction, into the pulmonary vessels, into the lungs, and then forward. And then we have left ventricular failure due to hypertrophy or due to ischemia or due to whatever, and the left ventricle is not doing its proper function. So the left ventricular failure will eventually lead to more and more work on the left atrium. The left atrium will fail. And when the left atrium will fail, more and more blood will start pooling in the pulmonary vessels. And what will be the consequences of it? Decreased cardiac output. Obviously, if left atrium and left ventricle failed, they're not pumping the blood like this. They're not working as a pump. So if they're not working as a pump and they're working like this, there's decreased cardiac output. And activity intolerance and signs of decreased tissue perfusion. If there's decreased cardiac output, if the blood coming out of the heart is not up to that level that it satisfies the requirements of the body, what will it lead to? It will lead to signs of decreased tissue perfusion. Which tissues will that be? Peripheral tissues basically will have cyanosis. All of these signs which are very prominent, and they will be happening at the distal levels because the basic organs, the vital organs are going to get their blood supply even in that stage. They cannot be compromised. But the signs of the less tissue perfusion will come in. Then comes pulmonary congestion because if left atrium fails, pulmonary vein starts pooling the blood. The blood is coming rightly from the right heart. rightly from the right ventricle into the pulmonary vessels, getting oxygenated, but it's going to left atrium. When it's going to left atrium, it's pooling because left atrium is failed, left ventricle is failed, so it will start pooling and it will lead to pulmonary congestion. And what will pulmonary congestion lead to? Impaired gas exchange. Now more and more blood is pooled in. How in the hell are those lungs supposed to oxygenate all of this blood? This will lead to cyanosis and signs of hypoxia. Patient will be respiring like this because they're in hypoxic. They're not. If so much blood is pooled inside of this vasculature, when so much blood is pooled inside of this vasculature and lungs have to oxygenate them, so what will happen? More and more oxygen will be required, and patient will be hypoxic. But cyanosis will be very visible because the blood is not getting enough oxygen. Next on we have pulmonary edema. It will start leak. The fluid will start leaking, and it will lead to pulmonary edema, and that will lead to orthopnea. What orthopnea is? Orthopnea means if a person sleeps at night, even in that stage, it's actually the fourth or fifth stage of dyspnea. Dyspnea means not getting enough oxygen, restlessness, breathlessness. Now, orthopnea means it's up to that stage that even a person when sleeps doesn't get enough oxygen to satisfy the needs of the body. The patient will just wake up, sit, and take a lot of air in so that it can compensate for that oxygen. That's called orthopnea. So this pulmonary edema will lead to cough with frothy sputum and paroxysmal nocturnal dyspnea. Paroxysmal nocturnal dyspnea means in periods at the night dyspnea will be happening. That's actually orthopnea. And cough with frothy sputum means patient is going to develop cough because more and more fluid is going to be expelled out of those vessels, and then this frothy sputum will be coming out, and that's a sign of left heart failure. Next, now we have systolic and diastolic heart failure. This is diastolic heart failure. What's going to be affected? Aorta, thick, stiff heart muscles, left ventricle, right ventricle. Now, in diastolic heart failure, these will be the affected sites. Right ventricle, thick, stiff heart muscles will be affected, left ventricle will be affected, and aorta, as you can see. But in systolic heart failure, thin, weak heart muscles. One second. So, what's the difference between these two? Diastolic heart failure means when the heart is failing when it's pulling the blood in. So, it's because of thick, stiff heart muscles, and left ventricle is not working properly, and right ventricle and the aorta. But what happened in systolic heart failure? Hypertrophy is happening. This hypertrophy has led to this state. The walls are very weak, the walls are very thin, space is too much for it to cover. These are thin, weak heart muscles. They won't be able to contract. They won't be able to give the blood out. If they're not contracting enough, it means systole is not happening, and that's what is called systolic heart failure. Next on, we have clinical features of left-sided heart failure, and then we have clinical features of right heart failure. What are going to be the clinical features of left heart failure? First of all, respiratory distress with exercise. Why? We just talked about it. You have to know it. Okay, I give you a second, but I think even if you know it, I would revise it for you. Respiratory distress with exercise means if left heart is failing, the blood is pooling in which veins or arteries? Pulmonary vessels. Pulmonary vessels are congested. So the patient is going to develop orthopnea one way or another. So in the midway, patient is going to have respiratory distress with exercise. When the patient walks, when the patient exercises, that patient is not able to compensate the body with proper oxygen. So it's going to have respiratory distress with exercise. Orthopnea, we talked about it. Patient won't be able to sleep flatly on the bed. Paroxysmal nocturnal dyspnea. At night, when the patient sleeps, the patient will wake up. The patient will take deep breaths because the patient is not consuming enough oxygen. The patient is not taking enough air in for oxygen to satisfy the body needs. That's what paroxysmal nocturnal dyspnea is. Edema. Edema is happening because more and more blood is pooling inside the vasculature. More and more blood is pooling inside the pulmonary vasculature. So the fluid will leak out and will lead to pulmonary edema. Patient will be confused because confusion is actually that sign we talked about, the signs of less tissue perfusion. When this tissue is perfused uh, less in the manners it was perfused before that in a normal state, patient is going to have these signs and symptoms. For mental state, for the brain, it will be confusion. It will be memory loss. It will be disorientation. And in the term of muscles, if the muscles are not getting enough oxygen, the muscles are not getting enough perfusion, what will happen? Fatigue. So all of these are signs of left heart failure, and all of this will lead to weakness. Patient is fatigued, disoriented, memory loss, confusion, edema, paroxysmal nocturnal dyspnea, orthopnea, and respiratory distress exercise. Now, one thing you have to remember, when the left heart failure has happened, it will eventually lead to right heart failure. How does that happen? Okay, if left heart is failed, pulmonary vasculature is affected. The blood is pooling in pulmonary vasculature. Here the blood is pooling in. Now, if the whole pulmonary vasculature is pooled, what will happen then? Now the blood will start pooling in that artery, that pulmonary artery which left the right ventricle to go into the pulmonary vasculature. The blood will start pooling, and it will lead to right ventricle eventually. Now the right ventricle will be filling. That will lead to right atrium eventually. Then the right atrium will be failing. So left ventricular failure can lead to the failure of the whole heart. So when you see the clinical features of left heart failure, you can say that it will lead to right heart failure eventually. And this weakness, can you memorize the point I told you that in GI, patient will have GI congestion and it will lead to all of that weakness? Yeah, it's one of them. Next on we have critical features of right heart failure. We just talked about it. Hepatic and splenic enlargement, peripheral edema, pleural effusion, ascites, venous congestion, and hypoxia of kidneys and brain. Now let's explain them. Hepatic and splenic enlargement in terms of that if right heart has failed, right heart is getting the blood supply from where? From the venules, from the veins. So it will affect basically the veins. And from where the veins are coming in? From all of these structures. When the blood has started pooling in the veins, it will affect all of these structures. It will lead to hepatic and splenic enlargement. It will lead to peripheral edema because the pooling is happening, the fluid will leak, it will lead to peripheral edema eventually. Pleural effusion. If it's being pooled in, pleural effusion is not going to be far away. Pleural effusion is going to happen because of this pooling of the blood. Ascites. When the blood is pooled inside the abdominal veins, it's going to leak and it's going to affect the abdomen, and that will lead to ascites by the collection of a lot of fluid. Venous congestion, GI congestion, kidneys will get congested, all of that. So venous congestion will be happening because the blood is pooling in the veins, so veins will be congested. Hypoxia of kidneys and brain. Now, hypoxia of kidneys and brain, how does that happen? If right heart has failed, it won't be able to push the blood into the respiratory system, into the pulmonary vasculature. If the blood is not pumped enough into the pulmonary vasculature, if the right amount of blood is not pumped into the pulmonary vasculature, right amount of blood won't be leaving out of left ventricle. Right amount of blood, if not pumped from the right ventricle, it means less blood is getting oxygenated. It means there's less blood coming in to the left atrium. It means less blood is coming into the left ventricle. It means less blood supply or less stroke volume or less cardiac output is going to be there. If the cardiac output, stroke volume is going to be less, the tissue perfusion will be affected. If the tissue perfusion is going to be affected, yes, the body and the heart and the left heart will try to compensate the vital organs first. But if it's compromised up to very toxic level, hypoxia of kidneys and brain will happen. Kidneys won't be getting enough oxygen, the kidneys will go into hypoxia. The brain won't be getting enough oxygen, the brain will go into hypoxia. And what will be the initial signs? We talked about it: confusion, restlessness, hallucinations. So this is how you differentiate between right heart failure and left heart failure. But one point you have to memorize that yes, left heart failure will lead to right heart failure eventually. So this is how we just gather the whole lecture in one point, that these cardiomyocytes are very major in the contractility of the heart. They gather up, they form sarcomeres. These sarcomeres are contractile units. They're contracting, but the normal length is 2.2 micrometer of a sarcomere. 2.2 micrometer. If it's more than that, if it's stretching, it's going to fail. It won't be able to contract properly. If they're not stretching, if they're shrinking, H zone and M line will go away. Even that's not good. So one way or another, that affects the whole heart. If the structure of the heart, if the structural activity of the heart is affected at a very minor level, it's going to have impact on the very major level, at the very basic level. That will lead to structural damage. That will lead to, if that stress has happened for a long time, it will lead to structural damage. And when the structural damage happens, this kind of left heart failure and right heart failure, which is functional damage, will happen, and so on. So you have to memorize what these structure units are and how and in what way these pathologies affect them, and in turn, they affect the heart and the functional capacity. Thank you for watching.